Okay, I'm not sure. I haven't heard from Iype. I'm sure he's scrambling to get things going. Right, Harshad? Still waiting to hear from Iype. I'm sure he's feverishly working. Hi, Ike.
Hey.
How you doing?
John,
Yeah. How's it
we are
going?
in the lab, John. Everything is setting up.
Okay.
Can you see the lab?
Yeah. Okay,
This is the lab, man.
you want to take us on a tour, or are you busy?
No, you can see these guys setting it up. So we thought we'll start by 10. That's what we thought. So
Okay.
um,
So
so now
another half hour.
Another half an hour we'll be ready.
Okay.
See,
Okay, so
one of the best labs in the world, man.
Okay, well, I'll tell everyone to wait for a half hour.
Yeah. So maybe what we can do is you can put me onto the Zoom. I mean, I will connect to the Zoom right now and I can talk to those guys first.
Okay.
Right now.
Get on the Zoom.
While they're doing it, I can talk to them. Okay.
Okay, do it now. Okay. Okay, as you heard, he said we're starting in about half hour, so just keep your seat there. Here's Ike now. He's going to explain what he's going to do. Okay,
Hey,
Ike,
we are in the.
hold on, Ike, let me introduce you, okay? Hold on. Okay, let me start. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good evening. It's Dr. John Bennett from Neurosurgical TV in Miami Beach. It's not sunny. Right now, it's 11 o'clock at night. We're having an impromptu live cadaver section with Iype Cherian. He's now at Krishna in Cherian, India. Okay, Iype, I'll turn it over to you to explain what we're going to do. Welcome.
So, John, this is the lab. All of you guys. So we have the lab. So you can see this is the Esculap Academy lab. So we have the scanning, the 3D printing, the simulation, all that in here. We have the changing room. This is the Esculap Academy. I mean, I'll just enter in here. And this is the cranial room. So we have the 3D 4K screens, and we have all the microscopes there. And you have the team here. Nihal is trying to set the Zoom up. So we have the smart TV and the Zoom facilities here. Okay. So we have operating microscopes on this side. And so we have set it up as one of the world's best labs. So most of the, most of the neurosurgeons, young neurosurgeons, we are teaching them microvascular anastomosis, cranial base, endoscopy. We have a spine room as well. So on the other side, we have all the facilities required. And this is the fresh cadaver. So you can see our team. So you have the OT team, Dave from our ENT skull base part will be doing the endoscopy. Afsal is a German board certified neurosurgeon. He's our fellow. Vishal is our senior resident. So we are getting ready for the craniotomy right now. So the cadavers are very fresh. So we get them. So I'll go ahead and mark the flap, guys. So, I'll go ahead and mark the flap, and then we are going to show you guys step by step how to go and proceed from approaches. Which means, we're not going to show you anatomical dissection just. We're going to show you with the pterional craniotomy, how do you do a single piece FOZ? I don't do it much of the time, but right now, if you want to do a single piece FOZ, how do you do it? And with a single piece FOZ, what are the pathologies that you can get into? So we'll talk about what is axial unlocking, what is sagittal unlocking. We'll go intradurally, open the sylvian cistern, and then we'll go transcavernous, we'll go anterior petrosectomy, and we will literally unlock the entire skull base and outline the anatomy of the carotid, the cranial nerves, everything, and then show you how is this anatomy relevant to your daily practice. This is precisely what we are going to do. I mean, I want you to share the link to as many young neurosurgeons as possible so that we are doing this in this place with the best facilities and the most freshest of cadavers, and with a very, very committed team. So I want everybody to learn. This is the purpose. Okay.
Can you go over the schedule, like what you're gonna do, step by the next step?
Yeah. So today we are going to first raise the flap, and after I raise the flap, I'll show some tips of how to reach to the zygoma very soon. And after that, we will do a subfacial dissection of the zygoma. We'll divide the zygoma here, keep the bone. Then we will raise the temporalis flap. Then we go ahead and do a single piece mini FOZ, fronto-orbito-zygomatic craniotomy. And after that is done, we'll show you the secret of the FOZ and the exposure you get with the FOZ. And then after that, we are going to go ahead and show you transcavernous dissection. In fact, first pericavernous dissection. So the pericavernous dissection will help you to take the temporal lobe away from the cavernous sinus. We will outline all the cranial nerves, everything. And after that, once that is done, we'll do extradural clinoidectomy. We'll show you how easy is extradural clinoidectomy. And once the extradural clinoidectomy is done, then we'll go ahead and show you the anatomy, extradural anatomy of the optic nerve, the carotid, the proximal and the distal dural ring, and then we open the dura, and then we release the third nerve first, and then we cut the dura tentorium between the third nerve and the fourth nerve. Then between the 4 and V1 cavernous window we'll open. We will give you transcavernous exposure to the posterior fossa, to the basilar and everything. And after that, we'll go and do an anterior petrosectomy. We will do that. Guys, unlock the microscope, please. Unlock the microscope, please. 1 second. Unlock it.
We lost the sound there. Let me see what's going on. I was just posting this on Neurosurgery Cocktail, which is a big group, as everybody knows. Hey, Iype, I lost you there.
Hello, John.
Yeah, okay.
Yeah, so we are joined by our foreign fellows for this time will be Afzal from Germany. Then we have Bilokneomidis from Greece. And we have Ivan Jeremy from Guadalajara, Mexico. So these are the 3 foreign fellows we have this time. So this dissection is going to start right now. So I'll mark the flap and I'll get ready with the dissections. And in another 20 minutes, we'll be showing you how we'll be showing you how we raise the flap, how we do each and everything, all these steps that I just mentioned. So once more, I'm going to show you the lab here. We have operating microscopes for 6 operating microscopes. We will have the endoscope, both the Esculap EOS and the Sanma Yoko. The Sanma Yoko is the exoscope that we have developed. And we have the 3D 4K screen there. We have the 3D 4K screen there, so everybody in the lab can see everything in 3D. And these are the operating microscopes. You have the endoscopes, you have the drills, and you have fresh cadavers from the anatomy department. So this is the facility that we have for the cranial part, and then the spinal part, and then of course we have a facility where we can do 3D printing, we can simulate, we get scans, we can use medical holodeck to reconstruct and watch different tumors, simulate different tumors in virtual reality. We have that, and these are the changing rooms, and this is the Esculap Academy lab. So we have this in Karad, and you guys are welcome to come and stay with us for 1 month. We have these programs where we have we invite you guys for a month, and then we'll have 1 to 2 cadaver dissections during that times, and plus we see a lot of videos, and we sit down with masters. I mean, we will be calling masters from all over the world as well. I'll be teaching skull base and vascular for sure, but then we have Charlie Teo coming by January 2nd week. We have Charlie Teo here for quite a long time. We have Japanese masters coming here. We have Vlad Benesh for supracerebellar infratentorial approach. So this coming year, we having a lot of meetings, and in August we are having one of the largest meetings here. 250 bedded neurosurgical hospital is going to be inaugurated. So state-of-the-art facilities, intraop, CT, VR, exoscope, robotic endoscopic holder, everything. So we would like you to come and share. And this everything that we are doing, that August meeting, the theme will be innovations. So innovations. It's anybody who has done any innovation, whether from Africa, South America, any place, any innovation is welcome. Okay, if you want to talk about the run-of-the-mill thing which you've been doing for 50 years, don't come. If you want innovations, whether it is in education, VR, AI, surgical technique, anatomy, anything in innovations, come here. You don't you come here as our guest, and after that, in August most probably is going to be the August last week. So we'll tell you the dates, and the brochures will be out soon. It'll be a large meeting, and you're all, August is a beautiful time in Karad. So you're welcome. So give me 15 minutes, and in 15 minutes we are going to get the flap and everything ready, and then I'll get back to you guys again. Thank you very much.
A quick question, Iype. Are you have you done any webinars yet, or is that brand new? The lab brand new?
The spine lab is ready too, but then the spine lab is not as ready as the brain lab. So the spine lab, we are getting our aim. We have a minimally invasive spine surgery team, and I'm not in that team. So it's being headed by Dr. Chinmay and Dr. Emmanuel and Dr. Ramdas. So they do all the minimally invasive work, endoscopic spine work. So we have the cadavers for that as well, but we don't have so many sets like in the cranial set. We have only a couple of sets available. So we're not in a position to do a large course at the moment, but very soon this year we'll be able to do that also in the spine with respect to endoscopic spine and minimally invasive spine and all that.
Does anybody have any questions on the panel right now for Iype? Hello, Harsha. Say hello to Harsha.
Hi.
Who's this?
Hi. Harshat Parekh.
Hey,
Can you hear me? Hey.
Hey,
Oh,
I can see you
wonderful.
now.
Wonderful lab, yeah. I'm so impressed with the lab. Superb lab.
Thank you, Harsh.
Superb, yeah. I can see such a spacious, clean, and wonderfully made. I must compliment.
We have the 3D screen here, so it's 3D 4K. You can see everything in 3D, whatever we are dissecting, and
Yes.
everything. Every station has TVs, and all the TVs can be connected to the central monitor here. And the central monitor, we have the Zoom and we have the speakers, everything, so that I can conduct a class, virtual class from here. And all of them, these are operating microscopes, not the lab microscopes. Harsh.
I can see it. Huge thing. Yeah. A lot of investments have been done on that. Wonderful. It requires a lot of money also.
Yes, we thought we'll put that in the initial stage itself before the institute gets ready. We'll put that in because a lab is the most important part for us.
You are a great asset. You are a great asset to Karad.
Thank you,
Because
Harsh. Thank you very much.
I'm living in Maharashtra and I know what was the condition there and what you have changed it. I must admire.
Thank you so much, Harsh. I mean,
wonderful.
I'd really like you to come and see the lab. I'd really like to host you.
I'm very tempted, very tempted to come. After seeing, to learn there something superb.
Now we got a fantastic team also. These guys are starting with the craniotomy. And today I'll do a single piece OZ, mini OZ, and then after that, we'll take it from there. So every step, anybody has any questions, I'll be coming out and I'll be answering these questions. We'll go in detail today, the entire day till 5 o'clock. We are in the cadaver lab. The whole team is in the cadaver lab. So anybody who has any questions are most welcome to ask me and we will clarify it for you.
Great.
I'd like you to meet Yandong Su. He's a neurosurgeon from China that also does cadaver labs. Yandong, can you say hi to Iype? You probably know him, right?
Hello, John.
Hello.
Hello, Iype. Hello.
Hello.
Very wonderful setup of your lab. Yeah, very beautiful.
Thank you very much.
Very advanced. Yeah, and I immediately joined a neurosurgical education platform in China to webcast your dissection to all Chinese neurosurgeons. And now I think maybe there are hundreds of neurosurgeons watching your dissection workshop.
Yeah,
and
so
also,
we would want you guys to participate. In August, we want a large contingent. Professor Guo, Professor Wang, all these guys are my great friends. I mean, China I have been to more than 20 times. So I have come and led so many dissections there from 2011 onwards. So I would really like all of you to come down to Karad and participate with us in August.
Okay. And by the way, I will have my dissection workshop in a few hours about the modified transcochlear approach. If it's okay for you, I invite you to attend my webinar and to have your valuable comments.
Yes. I'll be very honored to.
Today's Cadaver Day. Today's Cadaver. We have your webinar, and then we have Yandong's webinar, back to back.
So today's dissection day.
Yeah, today's dissection.
Today's dissection day.
Is there anybody else on the panel that has questions when I ask Iype?
John, I'll just go and start the thing. I'll mark the flap and things, and I'll join you. Babar, can we have a camera here so that we can can you connect the microscope feed into the Zoom feed? Okay, we are going to connect the Zoom feed to the microscope feed in another 10-15 minutes, and after that, I can be explaining from the Zoom on the microscope feed.
One question, there's someone I need.
Yeah, sure, John.
Somebody I need to contact during the telecast if there's any problems. You're going to be busy. Is there anybody that I can contact and say the camera's off or this is off? Is there someone like?
Yeah. So Nihal, John is going to contact you. So you zoom in onto another one. Yeah, you zoom in onto another one. You just tell him that you are. So John, I'm going to put in Nihal's number for you.
Okay. I'll contact him if there's any problem.
Yeah. So he's raising his hand. See, can you see me on the another Zoom?
Yeah, there he is. Yep. Okay.
Join as a panelist.
Okay, he's coming in now.
John,
Yeah, there's Nahal.
so Nihal will be with this computer.
Okay,
I am leaving now.
okay.
Nihal will be with this computer, and we are starting. We are going to start. We will be. We'll be having the. So we have the webcam also activated right now, and we'll be very soon. We'll be giving the microscope feed. We'll be giving the microscope feed onto the Zoom.
Okay.
Okay, guys, ready for marking?
Hey, Nahal, can I talk to you for a
The
second?
microscope feed Zoom में आएगा.
Okay, well,
क्योंकि ये इनपुट आउटपुट है अच्छा इसमें इनपुट के लिए क्या डिस्प्ले में चेक करेंगे अच्छा ठीक है
Give me gloves and. Hey boys, give me a. But give me an apron.
You know.
All set? Everything set, guys? We'll do the craniotomy, and after that, we'll do the craniotomy first, and then after that, the craniotomy will be installed on the cameras. Guys, one of you zoom into, get into Zoom, and then show the craniotomy on the phone camera, okay? Somebody show the craniotomy in the Zoom. Give me markers, please. Give me marker. Who's zooming on? Who's on Zoom? Yeah. Can you connect the scope to the? It is not. So can you connect the TV to the? Okay, so what do we do? We have the. What TV says? Don't we have raised hand? Can you make this into your panel?
Okay,
Don't tell me.
okay.
Yeah. See what you can do is.
What you can do is this TV, no? You can put it in front of that.
Oh, I see, we have another camera.
It's no problem. Image identity.
Yeah, I see, we have another, okay, another camera. Okay, good, I can pick one camera. Okay, yeah, you can change the other camera.
Dissector.
Okay,
Come scissors now and scissors now and dissect. Dissect above the pericranium. No, not with that scissors, please. Okay.
yes. Are you talking to me?
You are seeing, all of you? Hold it up, come. Both hands, hold it up. Yes, dissect now. No, it's too much light, so
Yeah, too much light, yeah.
stitches now. It's a very fresh cadaver. Put the lights on here. See, Babar, I would prefer that the microscope feed can be taken to the TV and that TV can be shown. So, see another microscope. See from another microscope, please. Maybe compatibility with the 3D issues or something. You bring it down. Hold it up. So here I'm going to I'm going to go subfacial. So all the way up to the, now hold it up hard. Hold it up hard. Hold it up hard, 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 hard. Hold it up hard, hard. See, in a second, we are on to the zygoma, okay? We are on to the zygoma. We are on to the orbit. So that's the zygoma. That's the zygoma. The light is not correct. Better now? Better now? So the zygoma is entirely dissected off. It takes me 5 minutes. You see that? That's the zygoма. There's an entire zygoma. You see? If you are in the right plane, how beautifully you can dissect this. You see? This is the posterior margin of the zygomatic arch. Comes all the way and like this. Okay? So the zygoma is dissected along with the craniotomy. This is what we do in cystonostomy. Come, retraction for me, retraction for me, retraction. Hold it up, and after that you can. All right, and give me a dissector. Give me a dissector. Yeah. So the back side of Penfield. So sharp one, sharp one. So you take out this pericranium so that you can connect it with the periorbita. You take that part to the periorbita. Very important that you take this to the periorbita. If you are doing an FOZ, very important. So now I am with this beautiful instrument, I can detach the periorbita from the zygoma. It's all about getting the correct instrument. So the periorbita can be retracted. So you can see the periorbita is completely retracted, supraorbital vessels. Now that is the zygoma here. The zygoma is nicely delineated. That's a fat pad. So you've done a subfacial dissection. See, the periorbita is the facial nerve orbital. So you can see now this proper skull craniotomy has been done. Okay. Now we are going to incise the muscle. Where is the periosteum? So, Mike, come hold this for me like that. Yes. Hold this. Come on, Vishal. Hold this. Take a gauze piece and hold the muscle, please. Take a gauze piece and hold the muscle. Don't pull it. Yeah, good. Very good. Yes. Knife now. Yeah. Hold it towards posterior like that. 1 second. Knife now. Okay. Pull it gently posteriorly. Yes. Take it off like that. Very good. Now pull it posteriorly a little bit. We detach this part. Pull it posteriorly a little bit. The fat, that fat is very useful for reconstruction. Okay. Now what we're going to do is we're going to cut the zygoma in 2 places. Okay. We're going to cut the zygoma in 2 places. Craniotomy now. Not cutter, craniotomy cutter. Come. More sutures here, more suture. 1 more suture here. Okay, come Afsal, can you use this to cut here and cut towards like that. Okay, can you cut it? Yes, sir. All right, go ahead. Huh? Yeah, peel. I'll peel it off. I'll peel it off. So the superficial layer has to be peeled off so that it's a clean cut. So you can cut towards here, cut here and bring it here. Okay, and 1 second, let me just peel this and make it separate. Okay, so you can first make this cut posteriorly. Yeah. Now you can hold this down. Hold this now. You can make the, now you can go from here to all the way to here. Okay. Yes. So this bone is free now, and the muscle, you will dissect the muscle. Come, cut the muscle. Hold it with a pad. Hold it with a gauze piece. Hold the muscle with a gauze piece. Yes. So and then now cut the muscle, please. From here. No. Right there. I'll show you. See, basically what you need is. So you're going all the way down. You are literally in the infratemporal fossa. So your skull base craniotomy so because this bone is coming along with the muscle, you can see it's give me the dissector, the periosteum dissector. So that's a infratemporal fossa. Take a stitch here. Take a stitch. Yeah. Rubber band, always on rubber bands. Do you have rubber bands? Yeah, so Vishal, rubber band, man. Another rubber band here. Come on. Knife, and we'll release the point for the key craniotomy. Tooth forceps. Knife to be changed for me. Okay. So it's all cleaned up. We got a whole base now. Now you can see the inferior orbital fissure. You can put your dissector into the inferior orbital fissure there. Can you see? It's standing there. Inferior orbital fissure there is been dissected out. This is infratemporal fossa. This is infratemporal fossa. So if you displace the lateral pterygoid muscle, you have the lateral pterygoid plate there. Okay. So that is what our boys today from the endoscope, they'll be coming. Now give me the perforator. Have you been able to connect the light there? So for the FOZ, we need one in the keyhole, one here. Hold the head, please. Hold the head. Okay. So two holes. And now what we do is we make a cut all the way like that. Cutter now. Before that, give me metronic drill now. Get the cutter ready and get me the metronic drill first. Metronic drill. We're going to do the grooving drilling. It's called the grooving drilling. So the grooving drilling starts from the keyhole and goes to the second hole, okay? All the way along the base of the brain, okay? So I'm going to put in the microscope there. I will reduce the light. Is the light reducing? Can you connect any other microscope with the TV? That's very important, the TV. So give me a dissector. Get me that's the dura. That's the dura there. That's the orbit. This is the orbit. So keyhole should always be in such a way that you could see you could have one hole in the orbit. Where's the metronic drill ready? Reduce the light on this one, your camera, on the camera. No, on the camera, reduce the light. Try and reduce the light. Now, as soon as the microscope gets connected, it's okay. Are you able to connect the microscope? No, we need to take it, not this. We need to take it into a screen. Can we take the microscope into a... Yeah, so then use another mic. Let's use another microscope. Please take another microscope and connect it. No, that is the only way to go ahead. Otherwise, this is just a temporary solution. Please connect another microscope immediately. Come. Shruti, take the HDMI cable and connect it to the main. Use the Leica M50, M520. The camera is there, ma. While we do the craniotomy, please connect the microscope onto the... हाँ ठीक है तुम वो दिखाओ मेरे को but the whole point is at the end of the day you should have the microscope feed, otherwise Drill ready? Yes, sir. Okay. So we have to drill in this direction. No, I cannot use the man. I need the groove drilling. Man is for these cuts. First, I'll make this cut. Okay, I can use the man during this time to. Okay, fine. Without light only? Okay. Where's the man? So I'm going to make the FOC cuts. Hold the suction, please. Irrigation for me. Come. So the first cut goes all the way. Hold the head, somebody, please. Oh. Okay, gauze piece to me. Yes. Right. No, somebody has to protect. Somebody has to help me. Somebody has to hold the head. Okay. Right. So the second cut goes here, comes down and comes to the keyhole. Okay. Okay. And comes the keyhole. All right. So now we have only one cut. That is with the drill. Can you get me the drill now? Drill ready? Metronic drill. Metronic drill. What do you mean? Okay. So move the man away. Get me the. Get the microscope feed on, and after that we will go and zoom in. Just get the microscope feed on. Otherwise, there's absolutely no point. From here, I'll first do the drilling and then take out the bone. And after that, we need the microscope feed on. The microscope feed ready? Huh? Shruti, call Hit. Call Hit. Tell them. Just put this up. No. आ गया
Okay, I think we lost the audio. Hello, is anybody there?
So the FOZ would be first hole would be here, the keyhole. Second hole would be just above the zygoma. 2 holes, just 2 holes. The first cut goes all the way from here to the orbit. Somebody protects the periorbita and then puts the B2 from here and then cuts here. Okay. And then that is the first cut. The second cut is with the B2 straight. Okay. And then third cut, that straight cut is connected to the keyhole. So first 2 holes, first cut, second cut, and third cut. Okay, it's connected to the keyhole now. Okay, and the fourth cut is like this. It's a grooving drill. So I'm waiting for the drill bit. Once the drill bit comes, I'll make that hole.
Oh, I lost the audio there, right? I don't know what happened. Hello, Iype? Hello, can anybody hear me? Iype? Hello, I need to connect to somebody, if possible. Hello, Iype? Can't hear you, Iype. Or anybody in the lab, please notify Iype that I cannot hear. Is anybody in the lab that's listening here?
I think now they are waiting for Julia.
Oh, okay. So nobody.
Yeah, I think now they are waiting for Julia.
Okay,
Metroni Julia, yeah.
here we go.
Hello, John.
Yeah, I can hear you.
Hello, John. Can you hear me?
Yes.
John, we'll be back in a moment. We'll be back in a moment.
Okay.
There's a issue connection with the microscope, so we'll be back in a moment. Okay.
Okay, who's this?
Hello. Can you hear me?
Yeah, yes. Who's speaking? Who's speaking?
This is Salona here.
Oh, okay. Okay, well, we'll just wait here.
Okay, sure. Thank you. Thank you.
Yeah, I
Sorry
need
for the
to,
inconvenience.
hello, I need to keep in contact with someone. Will you be that person? Because I can't tell them if there's no sound.
Yes. I'll be available.
Okay, so I'll be communicating with you, Devandan.
Sorry?
Your name is Devandan, right?
Salona. John, it's Salona.
Okay. Very good. We'll be back. Birahim wants you to explain the cuts again. I wonder if that would be feasible once it's stopped. Paranit? Okay, I'm just perhaps getting too excited. Just hang on. Put another camera on. So Yendong, you know exactly what they're doing, right?
Yeah, I understand everything. And it's a coincidence. The Professor Lab had a chapter for Professor John Akiram's textbook several years ago about the cellular region. And Professor Lab's chapter is about the transcutaneous sinus. And now my friend is translating this textbook into Chinese. And the Professor Lab's chapter is translated by me.
Oh, okay. I know, perhaps, I don't know if you know, are all those microscopes the same? There's like 6 machines in there. Are they similar or different models?
Yeah.
They're different?
Professor Lab's microscope is more advanced. It's more advanced than me, and it's more complex.
Oh, okay.
Yeah, I see. I saw his microscope is this.
Yeah, I wanted to take a tour, go over each one to say, what does this model do? What do they say the advantages are? What do they say the disadvantages are? You know what I mean?
You mean it different? You mean the difference of the modular or microscope?
Yeah, to see if it's different. What makes it different? Why is it better? Why is it more useful?
I think maybe first one is light source. And then is the balance system. It's very important. Balance system. The microscope, the head of microscope is very wet. So you have to have a very good balance system. And then it's the light.
Very wet. Oh,
Yeah.
the microscope has a lot of water.
Yeah, it's very heavy. It's very heavy, and you have to make the microscope very flexible, so you can have a very flexible manipulation during operation. So you have to have a balanced system for microscope. This is very important. And also another.
Go ahead, go ahead.
Hello.
I can hear you, Iype. I don't know which camera. Are you working on a different camera?
Can you hear me?
Yes, I can hear you now.
Can you hear me?
Yes, we can hear you now.
Yeah.
I'm sharing the screen till the microscope feed comes online. I'm sharing the screen.
Okay.
Yeah.
Okay, you're sharing it. You're very bright.
Okay, we are.
Very bright.
We're going to share the screen first, and till the microscope comes online, I'll show a few. I'll show exactly what we are going to do.
The screen is very light.
Screen share. Okay, I'm sharing the screen now.
Okay, very good.
We're going to
Yeah.
show you exactly the dissections that we were doing. Here, we're not going to go ahead and do the FOZ. The same thing that we were doing right now till the microscope feed comes online. We are going to, it is the same feed, which is the same dissection which was done in 2015 in our institute. So you can see I am identifying the zygoma. We've gone subtemporal, so that is a zygoma there. That's arch of the zygoma. So this is a superior temporal line. It's very important to outline the zygoma. Very, very important. So you can see the orbit here. The zygoma, the frontal process of the zygoma and the zygoma we have to outline. So that's the orbit. So for the skull base craniotomy, whenever you do it, it's extremely important that you have some few landmarks. One is the orbit. You can have a small craniotomy, but orbit remembers skull base. The zygoma is middle temporal base. So these two landmarks must be identified in any craniotomy. It's extremely important. Without that, if you try to do the skull base craniotomy, you're never going to be complete. Take out the temporal lobe, the temporal muscle. And further, you can define this. You may think I'm spending a lot of time on this, but this is very important. So that we have put the keyhole now. And this is the groove drilling that I was talking about. The groove drilling is from the keyhole all the way to parallel to the zygoma. It's very important. So the groove drilling, what it does is it takes off a lot of sphenoid ridge. Take off a lot of sphenoid ridge. Now we are making the cuts. Here we've not done an FOZ, we've just done a simple Cherian craniotomy. This last bit of the cut where you've done the groove drilling, once that's taken out, you can see the V2 there. That's a superior orbital fissure there. That's a temporal lobe there. That's a frontal lobe there. So you can see the orbital roof there. That is a superior orbital fissure. That is from where. So if you read our paper, the bloodless transcavernous dissection, we are going to be making the cut from there. This region, this is the orbitomeningeal band. You can see the orbitomeningeal band there. It's exactly where we are going to make the cut from. Once we make the cut, we'll be able to get into the pericavernous region. So I will show you the pericavernous region. So now we can go even up to the V3 there. V2, that is V2, superior orbital fissure. So I see I'm using the knife's backside and I'm making that cut now. You got to be very careful with this cut. Once you disconnect the temporal lobe away from the outer layer of the true cavernous membrane, then you're good to go. So you can see that. So now you can see that I am slowly releasing the temporal lobe away from the cavernous sinus outer layer, keeping on releasing it. Very important, this step is a defining step. So this is the division now that you can see that, and you can cut the rest of the orbitomeningeal band away, and you can see that the clinoid process is going to get better and better exposed now. So what I am doing is a mixture of axial unlocking and sagittal unlocking. So now you can see the membrane. That membrane is a true cavernous membrane.
Yes.
You can see that this is the level to, this is the plane to cut now. So it's very, very delicate dissection there under high zoom. So you can see the membrane over the cranial nerves there. That's the transcavernous membrane. So that's a clinoid process getting exposed. And Underneath the clinoid will be the third nerve. Acha, main aa raha hu. So that's the third nerve, that's the fourth nerve, that's a V1, all going into the superior orbital fissure. So underneath this membrane, you can see that I'm exposing the clinoid there. That's a cavernous sinus there. The entire cavernous sinus is slowly. This is our technique of bloodless transcavernous dissection. And I'll show you when I do it on the surgical case, there will be no bleeding. I mean, I don't need to inject anything. So this is pericavernous. This is not transcavernous. We'll go transcavernous later. So you can see that the clinoid is getting exposed. That's the cavernous sinus. Slowly this membrane we are exposing.
Dissection using a titanium cage.
So that's the medial border of the clinoid. And that's a optic nerve, extradural optic nerve.
Inflammatory tissue.
This part. This is the clinoid. This is the lateral border of the clinoid. So you can see the V1 there taking shape. That's the V1. You can see the membrane over the V1. The cavernous sinus is only till V2. So you can clearly see that over the V2, the membrane is not there. So you can see that the V2 is bare and V1, you have the membrane. So it's very important to delineate this membrane. And below V2, there is no membrane. So up to V1, 3, 4, V1 and 6 has this membrane over that. It's V2. So I'm going to dissect that junction. So now you can see V1, this is V2 and this is V3. This is the V3 here. So V1, V2 and V3. So the temporal lobe is being pulled away from the cavernous. Dissecting the V3. So we are going into interdural now. Temporal lobe is being pulled away from V3 now. And now we are going towards the Cherian ganglion. That's the Cherian ganglion. So that's the Cherian ganglion. So the temporal lobe is being pulled away. The frontal, you see the frontal temporal lobe is, the angle is open now, completely open. So you see the fourth nerve and the third nerve there. Entire cavernous sinus is open. So how we develop that plane? So now you have come to the Cherian ganglion. So there's a beautiful plane. If you can develop it, there's a beautiful plane. Sometimes you need some cystonostomy. I need to open the cisterns and do a cystonostomy.
Improve from them. Having power of 3/5 in the right leg and 2/5 in the. And he's able to doing his daily routine activities
Now
normally.
you are starting to expose the Kawase quadrangle. That is V3.
So
And there is GSP in there.
X-rays you can
The
appreciate
the Kawasaki quadrangle is already getting exposed.
implant after the removal of diseased vertebra.
So that's the V3. That is the anterior border of the Kawasaki quadrangle. That is GSPN there.
We noticed
This is
some of
GSPN.
patients in our study also. One patient develops DVT. One of the patient develops the superficial surgical site infection because he was diabetic, and 7 of the patients reported post-operative surgical site pain. This is the literature review showing some other
So you
studies.
can raise, and I sometimes earlier used to drill the V3 into the foramen ovale and mobilize the entire V3 and the Gazerian front into the front so that I can drill the true Peters apex. It's a very dangerous thing because the carotid runs very close to that. But of course, once you drill the true Peters apex, you'll get a fantastic view. So that's a GSPN. That's a GSPN. That's a V3. So we are exposing more and more of the Kawase's rhomboid. So you have the trigeminal impression, you have the trigeminal eminence, you have the meatal depression, that's the meatus, and this is the arcuate eminence. This is the arcuate eminence. So the Kawase you will have to take in charge of the cochlea here, and you can drill all the way up to here. You can even drill postmeatal to increase the size of the Kawase. This is a meatal impression. Arcuate eminence. So trigeminal impression, trigeminal eminence, meatal depression. So now we are opening the cavernous sinus. So you have the fourth nerve there. That is the fourth nerve. You can see the V1. You can see the V2. You can see the V3. You can see the sixth nerve medial to V1. That is the sixth nerve. Medial to V1. That's the carotid. This is the carotid. In the Parkinson's triangle, this is the carotid. That's the sixth nerve coming from the Doralose canal. That's the Doralose canal. This is the sixth nerve there. That's the carotid there. That's V1. This is V2. This is V3. Gazerian. And that's a Kawase rhomboid. So opening the dura there. So once we open, we can open the cisterns there. And that's the carotid. And that's the optic nerve. So opening above the optic nerve. So that's the opticocarotid. And now we'll go transcavernous. Now we take out the dura from here all the way up to the retrogazerian fifth nerve. We'll have a gateway. We'll have a real gateway into the posterior fossa to basilar pathology and everything. At this point, if we put a stitch, you can see that this is the falciform ligament of the optic coming like that and encasing the carotid as the distal dural ring. This is the falciform ligament, and this I've seen some publication where they show an eight curved ligament. This doesn't exist in surgery. That is for anatomists. For surgeons, for whoever is doing the surgery, please don't believe all these papers where you know, they talk about an 8. A lot of people ask me, there is an 8 curved picture. That doesn't exist. Okay, for surgeons, it doesn't exist. So what you do is, how do you cut? If you want to go into a transitional aneurysm, how do you do that? You take this falciform ligament, come over the carotid and cut this. I'll show you another example after this. I'll show you a beautiful example of a case where we did the same thing. So now we can drill the clinoid. Drill out the clinoid. The clinoid triangle. So you can see that the third nerve, the fourth nerve, the V1, and the optic nerve. And you can take out this clinoid completely. Between the optic nerve and the carotid, the carotid is the strut there. You release all the ligaments. The anterior petroclinoid ligament and the tent. You release it from the clinoid, and then you can take out the clinoid like that. Very gently, no, not a lot of rush, because if you take it out with a rush, so you can see now that is the falciform ligament and that is the distal dural ring. So after you take out the clinoid, and below is the proximal dural ring, which is the roof of the cavernous sinus, in fact. So this is the distal dural ring, and that's the proximal dural ring, which is the roof of the cavernous sinus. Now you very gently you take out the clinoid, because the last bit is called the shark tooth. The shark tooth can, it can hurt. So you take out the shark tooth very carefully, and that's the strut. So you can see intradural and extradural. That's a shark tooth of the clinoid. It's being taken out now. So that's the proximal dural ring attached to the carotid. So you can see the shark tooth. So that's a carotico-oculomotor membrane. That's the third nerve. The fourth nerve. Just below the clinoid is the third nerve. And that's the strut. That bone is the strut. And that is the intradural optic nerve, extradural optic nerve, intradural carotid. Extradural carotid is the transitional segment of the carotid. Now you cut this falciform ligament is coming over the carotid. You cut it, and you will be cutting the distal dural ring. You will be releasing the distal dural ring. Very important to open intradurally and extradurally. You have you know where to cut. If you don't do it like that, because the proximal dural ring is getting attached to the carotid wall, it's very easy to cut the carotid wall, especially in transitional aneurysm. So you have to open, and then after that you make the cut. So that's the strut. I'm defining the strut. The strut has to be drilled. The strut is anterior to the curve of the carotid. The strut is being removed now. Now opening intradurally. So that is optic nerve. This is carotid. This is the C3 carotid, which is going down. So you can see the carotid, C2 carotid, C3 carotid. So you can see the entire carotid outline. That's a falciform ligament and the distal dural ring extending on to as the anterior petroclinoidal ligament and the tent. You should know that these things are not they are termed in different nomenclatures, but they are the same. Okay. If you have confusion with this, because they are named as falciform ligament, distal dural ring, anterior petroclinoidal ligament, they're continuous. Okay. So please understand that they are not very big concepts. So you have the carotid here, you have the transitional cave here, that's the proximal dural ring, that's the roof of the cavernous sinus. This is the distal dural ring. And the transcavernous exposure now. I'm going to show you a video where we are doing a case like this. Yeah, so you can see the clinoid there. You can see the transitional aneurysm there. So the falciform ligament is going to be there. This is the clinoid. The proximal dural ring is going to be there. Okay. So the same approach under high zoom, cutting the orbitomeningeal band. Very bloodless. Okay. Some people tell me only in cadaver we can do that. No, you can do it in real case also. Okay. So that's the cavernous sinus completely getting exposed there. Temporal lobe is being now you can see That's the clinoid, and the aneurysm is somewhere there, medial to that clinoid. So that's the cavernous sinus getting exposed. So that's the third nerve there. That's the clinoid process. So the clinoid is getting drilled now. So the clinoid is getting drilled now. And lateral to the clinoid, infralateral to the clinoid is the cavernous sinus. So the entire clinoid is getting drilled now. You must notice that the clinoid is on the aneurysm, literally. So the clinoid is getting thinned out, thinned out. Thinned out, more thinned out. So here is the aneurysm. You would be able to see through the dura that the aneurysm is there, because I have the dural covering. So my drill is not going to go past the dura. So I'm going to release the dura from the clinoid very gently. So that is the optic nerve. That is the extradural optic nerve, just like what we saw now. That's the extradural optic nerve. And the aneurysm is down there. You can see the blackish discoloration there. So the strut, the clinoid is removed. The strut, we are removing the strut. You can see the aneurysm there. That's aneurysm. That's a bony strut. We are removing the strut. So you're drilling right over the strut. So that's the optic nerve. So all the bits of struts are being taken off right now, right over the aneurysm, so that I can release this dura over the aneurysm, and then I can clip it. That's very, very important, because if I have bone, I cannot release the dura. I'll have to cut the bone and the bone as well as, so I have to, the dura, it's impossible to cut the bone and the dura together. So you have to completely shave off the bone. And so you can release the aneurysm, especially in a true transitional aneurysm like this. You have to completely, it's not like any other paraclinoidal where the aneurysm is completely intradural. Here the aneurysm is extradural, part of it is extradural, true transitional. So it's very important for you to release all the strut and shave it all away, so that only the dura is remaining. Now I'm opening the dura. So you can see when you open the dura, part of this aneurysm is extradural. This is the optic nerve. As you said, as we said before, the falciform ligament and getting attached to the carotid. Okay. So if you take off the falciform ligament from this, and I mean you separate it from here, you separate the falciform from here, you can cut the falciform and the distal dural ring. So that's exactly what I'm going to do now, just like we did in the cadaver. So that's the falciform. and we are cutting the falciform. So cutting the falciform and coming to the dura parallel to the aneurysm. Now comes the proximal dural ring. I mean distal dural ring cut. Now comes the proximal dural ring. That's the roof of the cavernous sinus. That. So when you cut it, you will have bleeding. So you cut that, and now you are ready to put the clip. You can see the intracavernous carotid completely released. And now you can put the clip on. That's the intradural carotid. We are going into the cavernous sinus there. That is also released. Can we, that is 3D. Please take off the 3D, please, guys. Give it on the 2D, please. Because I will not be able to telecast 3D now. Please make it 2D setting karo. Okay. Now the microscope is online. So now what we are going to do is we are going to put the clip here. That is a carotid there. That's aneurysm there. We're going to put the clip now. Very easy now. But initial part was difficult. Always remember, when you are doing a so-called impossible job, it is not the job that is difficult, but everything behind the job and after the job. Before and after is what is difficult. Its clipping is very easy. You see now? Very easy. That's a intracavernous carotid. Unless I had exposed the entire proximal distal dural ring, everything I had cut, I will not be able to expose this part. So you can see this is and this is a small dog ear which is being taken off by this. And that's the intracavernous carotid. That's intradural carotid. Okay, and done. Thank you very much. Now we are online. So we are going to continue on with the dissections. Please give me a 5-minute break. Please give me a 5-minute break so that I can get these guys to get ready with everything, and I'll finish some work and I can be back. Okay, I'll be back in 5 to 10 minutes. And by that time, if you have any questions, please put it on the chat box so that we can answer these questions while we are doing the dissections. Thank you very much.
Okay, thank you. We'll see you in a few minutes. Okay, everybody. You heard it, so we just stand by. I myself am going across the street to get a good big cup of hot coffee. It's right now it's 12:30 in Miami. So I gotta get some caffeine in me. We'll be back.
So John.
John, good morning. Good morning. Could you please finalize this banner because people were asking me to send the link and the banner. Thank you.
Hello, I can hear you. Yes, yeah, hi. Yeah, can you hear me?
Hi, John, what is happening?
Okay, can you type what you just said, please?
Sure.
Okay, I can't understand what you're saying. Please type it. Okay?
Yes. And they here. Can you hear me?
Yeah, now I can hear.
So we are doing basic extension. How many participants are there? 13. 1, 3. Yes, sir. Right. Ask them all the best for that sector. We are going to carry right now. Bigger by Roger. You are now, you are flushed with the temporal base. Yes. So this is exactly the cranial that we need, plus with the temporal base. Yeah, that's. Very good. So we are going plus with the base. Observing the LPP with going plus with the base. I complete. Irrigation now. Very good. Very good.
Hi, the screen is too light. Can you hear me? Yeah, hi, can you hear me? Okay, let me text you.
Can everybody see the feed? Can everybody see the feed? Yes, it's yeah. Ora bisogna fare ora su del Okay. Little now.
It's still very light.
Can't see
So
anything.
you are bringing up to maximum velocity and then touch. Don't touch and then stop. Because it will be
Oh, Sean, you also can't see it?
okay.
John, I cannot see anything. It's all blurred image, plus the voice is also not clear.
Yeah, I see. Yeah, I tell them, like, we can't, it's too light. There, that's a little better. Okay.
That will be,
Yeah, we're gonna have to do something. I
Absolutely.
see, no, still not. Keep trying, we'll get it, we'll get it. Just gonna play with it. That's a little better, not too much, little better. You can see it now, Harshad, right? Better, a little better.
We can't see anything.
Oh, you can't see anything, okay. Can't see too much, type. You may be seeing it well in the lab, but on the internet, we can't see it well. We can't get a direct feed from the camera, right? Yeah.
Yeah, the screen is so small and so blurred. We cannot see clear.
Yeah, everyone can't see it. Can you hear me, Iype? I don't know if you can hear me.
Unless you are happy with the zoom and focus and everything, don't work, okay?
A little better. That's a little
Going
better.
towards the orbital angel band, something. As we described.
Harshad, is that better for you, Harshad?
It's a very light and faint image which we are seeing.
Right. Yeah,
Can't make out.
yeah, we gotta keep playing with the resolution, I think.
Swimming dog. Swimming is going around. Going just above you see, the orbital angel band connects the frontal lobe, temporal lobe, and the orbit. So, you need to take out the frontal lobe and the temporal lobe areas from the orbit.
Yeah, we can see the screen, and I know you are drilling the spinal wing, you are scrutinizing the orbit, but you know the resolution is low.
So the orbital band, give me the micro scissor. With one hand suction, please. So, the micro scissors, what you're going to do is, you're going to incise the micro scissors. You're incising the orbitomeningeal band.
Okay, they're working on it, Harshad. They know the problem. You might have to mess with the settings of the screen.
डाला है प्रोडक्ट हाँ
They're gonna try something else.
जरा इधर से क्लीन करो माइक्रोपोर किधर है
नहीं पूरे नहीं वो एक रखो
माइक्रोपोर
We're here, we'll wait.
Cut there. Drill now.
You understanding what I'm doing? So sometimes it's very easy for you to get lost.
इधर से क्लीन किया इधर से हाँ? नहीं नहीं लोग इधर इधर इधर
Superior fissure has to be exposed, bony exposed to the superior fissure.
वो अभिजीत उधर के बैठा था ना सिस्टर कोई बैठा था ना बोला चल आजा इधर से क्लीन करो
Okay, neurosurgery coach. Okay, I don't know why they're going to neurosurgery.
You can see on the Zoom how much high Zoom we are on. So, superior orbital fissure. Flush with that, we are taking the bone off.
लास्ट टाइम अच्छा था 3-4 दिन कोई 8 दिन कोई प्रॉब्लम ही नहीं था पता नहीं क्या हुआ और उसको फिर हुआ बोलते हैं ट्यूब डाला है ट्यूब दिखा
Yeah, that is not helping. It's not helping.
गाँव में ना सिस्टम
Now it's completely white. You have to solve this problem.
थोड़ा दो ना रिलैक्सेशन दो ना मैडम हैं आप पूछ पड़ते हैं
Yeah, I think you need to go into the settings of the screen. Do you understand what I'm saying, Nahal? I think
आपो ना because she's buckling हैं वही तो बोल रहा हूँ sedated and paralyzed
When we decrease the brightness now,
सिस्टर राइट एंगल ले लेना 2-3 बड़ा छोटा दोनों लेना तो फील आ जाएगा हाँ ये रीडू करने का लाइट ठीक करो जरा इसको क्लीन नहीं किया बरोबर गॉस्पी ये स्पंज है एक स्पंज है ना
so now I'm exposing the anterior clinoid process there.
इधर है ये वाला लाइट इधर सिस्टर 8.5 का ट्यूब लेना which number tube is this is which number
That's the anterior clinoid process getting exposed without any process.
तो 8 का लो सिस्टर
8 का सर
चलो ड्रेप दो सिस्टर
That's the anterior clinoid process. You can see everybody.
it's still too light. We
ड्रेप देना सिस्टर
cannot distinguish the anatomy. Cannot see the anatomy.
और लेना कॉटरी लगाना कॉटरी कॉटरी लगाया नहीं है नहीं पायल अलाउडी नहीं है ये लाइट बरोबर
Okay, now
It's a little better, but we still can't, it's still very white. It's a
देना
little-
कॉटरी लगाओ कॉटरी
That's better. Keep going, keep going. It's better how shot, right? Not the best.
स्पंज देना
Don't get so close.
That I'm not able to get the angle. That's
राइट एंगल देना सिस्टर, ट्यूब दिख ही रहा है वैसे। राइट एंगल दो, ट्यूब चेक करो। हाँ थोड़ा नीचे खींचो।
Sir, 8 number open tube.
हाँ
Yeah, hi. Yes, it's a little better, but it's,
light the under.
can you hear me okay?
let me use my light.
Okay, no, we cannot see, it's still very light.
डिफ्लेक्ट करो ना, ट्यूब देना सिस्टर।
Okay, can you
Tube gaya tao yeh laga.
the settings on the screen itself?
Yeah, I'll adjust.
Try that to make
डिफ्लेक्ट
it
करो,
darker.
करो डिफ्लेक्ट, दो ट्यूब दो। ठीक है वेट करो, इन्फेक्ट मत करो। देना सिस्टर।
Close.
इसको हमेशा ये खोलना चाहिए, तो ये बंद नहीं, ये नहीं खुलेगा ना तो निकलता नहीं। जल्दी डाला, एयर निकालो इसमें से, निकाला। डिफ्लेक्ट करो, डिफ्लेक्ट डिफ्लेक्ट थोड़ा सा।
Okay, you don't have to be so
Is
close.
there a way that I can do X-ray on this?
Please.
Better now? So I am keeping on deflecting out the and change this microscope please. Or is it going to be a problem? So this is the final process. The entire final is massive final process. Come bite it to me now. Bite. Bada bit. Third. Very fast. So I have amputated the ACP. Now dissector now. That is what I wanted to show you guys. See the ACP is moving now. Can you see? Can you see? ACP is moving now. So this is called amputation of ACP. Very simple. With a large pipe, you can do it. So now we have a clinoidectomy. So it says named after us. Oh, give me needle holder now. Now you hold the needle with the hold the clinoid with the needle holder. and out. And hold it again with the needle holder and out. And hold it again with the needle holder, push and out. Hold it again with the needle holder, push and out. Don't try to take it out in one piece. Huh? That is very gratifying, but that may be dangerous. Dissector now. That's the roof of the cavern sign. That side. Yeah, I mean, I would like the microscope to be. Give me the dissector now.
Can we move the camera? It's too close.
Sorry,
It's too close. The camera is too close.
it's zoomed in.
Can you see the picture on Neurosurgical TV?
Yes.
Okay, that's what we're seeing. We're seeing a very close picture. Too close. Back.
You're okay now?
Back, further back. Further back. It's still too close. Shad, what do you think?
Better now?
I think it's still too close. Can you move it back? The camera.
John, that's because we are zoomed in.
Okay.
So you need orientation, right? Give me switches now.
No, it's still very close and we can't see too much.
Yeah. So I'm zooming out, okay?
Okay.
That's the maximum zoom out.
Well, boy, that's really, look, if you really want to see what we're seeing, take a look at Neurosurgical TV on the front page. That's what we're seeing. Have someone hold up a smartphone to Iype's eyes of what Neurosurgical TV is showing, the type of picture. I don't think Iype would accept that.
John, I'm doing a transcavernous dissection,
Okay.
but I'll just show you now. Once I'm off with the
Okay.
liner now. Yeah.
Okay.
Scissors now.
Yeah, it's a good picture, but it's very.
John, can you hear me?
Yes, I can hear you. Can you hear me?
Yes, man, I can hear you clearly.
Okay, yeah, the resolution is good, better, but we're still close. But I guess we can't do anything about that, right? It's maximum zoom, right? This is probably good enough for what you're showing now.
And the last piece. And the last piece. Irrigation now.
Yeah, the resolution's fine now.
I'm going to zoom in, John, because I need to kind of. John?
Yeah, I can hear you.
I'm going to zoom in. orientation is the superior orbital fissure there.
Yes, I can hear it.
That's a cavernous sinus. You have V2 there. Give me the dissector, please. There's a fourth nerve coming there and going towards the Cherian ganglion. That's the Cherian ganglion with its. I can open and let out CSF from there. Can you see, John?
Yes. Good resolution. A little close.
What are you saying? Let's see. Same.
John, we missed the SCP drilling. And it is Zoom is quite a high, so we are not able to visualize the
have-
structure.
The carotid there.
Yeah, Harsha, that's as high as they can go on the distance. They can't go any further. That's the way I understand what they're saying,
Yeah.
because of the zoom or something. The resolution's okay, finally,
Mhm.
but you need a better view further away, correct, Harsha?
Right. That's third nerve. Third nerve. Can you see?
We can
That is
see,
third
but it's
nerve.
too close. It's too close.
Yes.
Can you see?
Yeah,
Third nerve. This is fourth nerve.
Okay.
V1, V2,
Okay.
and
Okay.
V3.
Okay. Yeah, we could see the nerves now.
Did you see?
Yes. The third nerve, fourth,
So
third, that is third.
third nerve,
Yeah.
third nerve,
Yeah.
your carotid, fourth nerve,
Yes. Mhm.
third nerve, fourth nerve, V1, V2, V3.
Okay.
Cherian ganglion.
Okay. Now it is better.
Yes, everybody seen it?
It is seen now.
Okay, third nerve, fourth nerve,
Okay.
V1, V2, V3, Cherian.
Yes.
Okay?
okay.
Yes, we could see that. Yeah.
Can you see everything? Guys, can you see? John, can you see everything?
Yes.
Yes, we can see.
Anybody
Yes,
has a
we can
doubt?
see.
Anybody has a doubt? I'm going to stop and I'm going to show you again. Drill now to me, drill. Actually, you have seen anything, man? Yeah. This is a beautiful transcavernous dissection now. Right.
Is it a PCP drilling?
the last bit of the clinoid. 1 second. That's the third one. I opened the dura. That's a carotid, okay? That's a carotid. Can you see? That's a ring. That's a third now. Can you see sir now?
Arshad, are you there?
That's a ring. That's a strut. So, straight away, what I am seeing is as soon as I release the third nerve sleeve, you know what? That's a membrane of Iype. This is the membrane of Iype, the posterior clinoid and the membrane of Iype. Give me a dissector. Large dissector. This is the posterior clinoid. Okay. So I am see, I am cutting the third nerve sleeve. I have dissected off the third nerve sleeve. I am cutting the fourth nerve away from the third nerve and dissecting the. I mean, focus in the depth now. Focus in the depth. Suction. Suction. That's the basilar. Can you see? That's the basilar.
Yes, we can see it.
You can see the basilar?
Yes.
This is
Just
transcameral
barely.
extension of the basilar top.
We're gonna have to work on this, Harshad.
Focus on, focus on.
That's the basilar top. Okay?
Yeah.
All right. Give me a dissector now. So you can see very clearly. You can see very clearly one P1, dusra P1, contralateral third nerve. Can you see the contralateral third nerve? Give me a smaller dissector.
Okay. A little,
Suction, small suction.
oh, very close.
Can you see the third nerve going down all the way like that? Can you see the third nerve?
Yes, we can.
Suction. Small suction. Small suction. P1, focus there.
Yes.
That's contralateral third nerve. Focus. That's contralateral third nerve. Can you see?
Yes, we can see behind the, yeah, P1.
Contralateral third nerve, contralateral superior cervical.
Yeah.
Uh-huh.
I have not even opened the dura now fully. Okay.
Mhm.
This is carotid.
Uh-huh.
Now, that is the entire basilar top. Basilar top. Okay.
Okay.
Is everybody seeing it?
Oh, Sean, I haven't been to many dissections.
Has everybody seen it?
Yes, yes, we could see the dissection now. Earlier, we could not understand what is happening, but at least now we can manage
Okay,
to
that's a
see.
little better.
I'm going to do an overview. Overview is carotid,
Yeah,
Okay,
third nerve,
yeah,
P1, contralateral third nerve,
yeah.
superior cerebellar artery, fourth nerve,
Mm.
V1, V2, V3.
Yeah,
that's a little better, Harshad, right?
yeah. Better now it is. Can he see optic anywhere near the carotid artery?
So, carotid artery, can you see?
Yes.
You
Okay,
can see
where is
the
your optic?
basilar top, the superior cerebellar P1,
Yeah.
contralateral P1, contralateral third nerve, ipsilateral third nerve,
Huh.
fourth nerve, V1. Can you see all that?
Yes, we see. Can you show us optic if it is seen optic?
You didn't see optic because I didn't expose optic.
Okay.
I will expose.
Yeah.
Now.
So you are in a optico third nerve triangle now.
Optic I will expose. 1 second. Give me a
Carotico third
second.
nerve.
That is optic.
Okay.
Can you see optic?
Yeah, we can see optic.
That is optic. Okay?
Okay. Yeah.
This one optic. Carotid. Contralateral third nerve. Ipsilateral third nerve. Fourth nerve. V1, V2, V3. All, everything. Okay?
Yeah.
All good?
All good.
Enjoy?
You have exposed extradurally only.
I'm going to expose. I'm going to open the dura now.
Okay.
Then we go through transcavernous. Dural opening now. Dural. Yes. Good, sir. That's the vein here. That's the vein.
That's a good picture, right, Harshad?
It is seen now clearly. He has opened the dura and
Yeah.
now is going subfrontally to see the structure.
That's better, a better picture, I think. Is it not true, Harshad, that the color is lighter when you dissect a dead brain?
You don't see blood na when you dissect. So there is a white color only.
Oh, okay.
Yeah, because you are dead brain, so you are not seeing the white color.
Right.
Initially, there was no focusing. Now, at least we could see something.
Oh, okay.
Yeah.
Yeah. So yeah, the color's not, it's whiter than normal, obviously.
Yeah.
Obviously.
I'm opening the vein also. You see the middle central artery there. That's the middle central artery. Can you see? That's the basilar. Now I'm going to cut the dura. I'm going to cut it. Just take it. I'm going to make a cut in the dura. So give me the micro scissors, please. Just take for me. That's the middle step. Hold this one here. Give me a large scissors. And make something called the cheek cut. Very helpful. Yeah. So put this towards this side. After one second. No, that lower one. Don't stick it. I'm going to release the third one. No. Okay. Okay.
Yeah, the picture's gotten much better. Yandong, are you there?
Now we show the third now entered tools, the carotid entered tools.
Oh, Shah, that's a good picture, huh?
Yeah, better picture now. Now it is a better picture.
Yeah.
Yes, I'm here, John. Now I'm preparing the specimen for tonight's dissection.
Well, I just wanted to ask you a question. Do you have problems filming off the endoscope screen?
Now I didn't do endoscopic dissection, but I think there should be one cable to transmit the signal from the endoscope. In
Yeah,
China, it's okay.
yeah, maybe you can talk to Iype about that. But I think the problem is the endoscope screen needs to be connected to the Zoom directly. It's an output from Zoom. You know,
Yeah,
and
you
not,
know, in
not- and
China,
not the screen, not a screen of the endoscope screen, because we're
I
filming
know.
the endoscope screen. We want a direct feed.
Yeah, I know. In China, we have so many lab surgery of endoscopy surgery, and we can see the screen is just like the screen only in the OR.
Yeah. Well, you saw the
Yeah.
beginning, the resolution was not good.
Okay, now.
Yeah, now
In
it's
China,
good.
it's okay.
Now it's good. But I think we need to trade secrets with each other about how to film things off the exoscope, etc. But I think it looks fine now.
So that's the candidate. Yes.
Okay. Right. Can I quit?
Everybody is looking. I think the pre-constant posterior pose are dura.
Okay.
Oh, we have more of this. Okay, fine. But this, see, if it is circular, you can see the, when you see a circular, P1 here.
Focus, yeah? Yes. I'm going to remove the piece. What's what are they saying? Give me a charism. One second. The posterior clinoid process. There's a 1 second. 1 second. Right now. Very gently. Yeah. Yes, okay. Right now. Right now. 1 second. Right now. Without that. Take it out. 1 second. Give me the. That's the posterior liner process. Cut scissors now. Okay. All right. Drill now. They have the very small. They have the smallest 1 millimeter zoom. Yeah. No. Yeah. No, smallest. Smallest. The smallest. Yeah. Can you give me the. Yeah, section now. Focus zoom now. Zoom. Yeah. I need more light. Focus there. Yeah. Let's posterior clinoid process drilled out. And you have basilar trunk there. You see the basilar trunk, everybody? Can you focus?
You can hear what they're saying?
No, I can't hear.
You can't hear anything.
Focus now. Hmm?
No. He's asking for the thread one.
No, this much.
सर के लिए मास्क दूसरा दे दो थ्रेड वाला
बांधा सर
Little bit, I can hear them, but can they hear them? Are they able to understand?
Hearing and what just we have. If it is connected to this one. That's okay. Sir, sound will be the another.
So third now, fourth now. Superior cerebellar. This is the interpedal suction there. Small suction there. I'm into the, this is the interpeduncular fossa. This is the interpeduncular fossa. This suction is, I cannot control. I don't like this suction. No, this is okay. So third now, superior cerebral lab, P1. Optic nerve, A1, very short A1, very short bifurcation. Can you see? Can you see everybody?
Yes, yes, yes,
This short bifurcation, very short bifurcation. We go posterior now, extradurally. Okay, you guys have a look around. I'll just ask them what they understood and what they did not. Okay, I'm coming out. Where can I interact with them? Huh? Now I can sit in front of some PC and then I can talk. What is this connected to? Can I sit down somewhere? Yeah. Harshad? Who's there?
Huh?
Can
Can you hear me?
yes, we can hear you.
Okay. Anybody has any questions?
No, the camera looks a lot better.
Huh?
The camera looks better.
So we've just dissected the transcavernous groove.
Yeah, so now Afsar is showing the gazillion ganglion there. Afsar, you can identify the V1, V2, V3? Hello, can you hear me?
Yes, we can hear you. Yes, we can hear you.
Yes, the fourth nerve is there, V1 is there, all going into the superior orbital fissure, V2 there, and V3. Yes. Gazillion ganglion. Show me the gazillion. Yeah, that's the gazillion ganglion. Show me the basilar top. Focus into the depth and show me the basilar top. The artery coming above the third nerve is the P1. Can you see the basilar and the P1?
It's a little cloudy, but we can see generally. How about you, Harshad? Can you distinguish that?
Yeah, now I'm seeing on the screen and I can clearly make out the basilar. Show me the basilar. Take a small dissector and show me the basilar. Yes. Yeah. Show me the P1. No, come above the third now, above the third now. Above the third now. Take your dissector and go above the third now. Yes. So that's the basilar bifurcation. So show me the other side. That's the mammillary body. What you're holding up is the mammillary body. Can you see the mammillary body? Those two are the mammillary bodies. And the mammillary, below the mammillary bodies is the basilar bifurcation. That's the basilar bifurcation. You can see the thalamoperforate artery is there. That is the division of the third nerve is in the crotch between the superior cerebellar and P1. That's P1. And that's superior cerebellar. Okay. The artery going down below is the basilar. Clear? Okay, Dave. Can you do the endoscopic transcavernous now? You guys start off the endoscopic transcavernous, okay? And maybe 2 hours later, we can go online again. All right. Once you finish, and then we will show from both sides. Afsal, you've seen the anatomy? Yeah. Okay. So now what we will do is let him do the transnasal. Yeah, you assist him and expose the. You guys go for lunch, and then once you expose the transnasal, we'll expose the same carotid. Everything will expose, and then we can correlate with this anatomy. Okay. So 2 hours later, we can go online. John?
Yes.
Harshad, you are here?
Yes, I am. Can you hear me?
Yeah.
Okay,
Harshad, can you see the anatomy?
Yeah, it was good. At the end, it was much better. It improved.
Thank you.
No, I'll talk to you. I'll talk to you after. Okay.
Okay, man. Okay. So going offline now.
Iype, it was nice.
Iype,
it was a nice dissection.
Beg your pardon?
It was a nice dissection.
Thank you very much.
Yeah, initially, we could not see properly, but later on, when you reached to the cavernous sinus, we could see the cranial nerves, arteries, and liliquest and basilar. And when you opened the middle Sylvian fissure, we could see. Initially, drilling, we could not see much.
I am sorry about that.
No, it's okay, but the approach was could not be seen. We started seeing after you started completing the SCP drilling.
I see. Now, what we will do is we have another side. We will do it some other time. We can do another side also with this. With this, maybe Monday, if we are not. We are trying to be free during this time. The fresh cadaver comes, and then try to dissect. Monday probably we'll do a paraganglioma. The retrostigmoid jugular approach to the glomus jugulare. That we are trying to do.
Okay, we'll be there. Thank you.
Right. Iype, listen, Iype, can you hear me okay?
Yeah, yes, man.
Yeah, Iype, we're going to have to end this transmission because we have another webinar coming up in a couple of hours. So
sure, man, sure.
We'll try to catch up with you next webcast. The next time,
yes.
The next, let us know when you want to go live again. We'll do it again.
Yes, man. Yes, yes, yes. So we will listen to Dr. Yandong.
Well, you know what, I think we have to connect the exoscope screen directly to the laptop. You know what I mean? Because we're really filming the screen of the exoscope. We're not really coming from the exoscope. Do you know what I mean?
Yeah, I understand. So the thing is, we don't have the exoscope right now with us. So the exoscope is, I mean, the Sanma will bring it very soon. EOS they'll bring it only for courses, but Sanma is going to keep the exoscope here. So once the Sanma exoscope comes here, then we'll be able to show it in. We are trying to figure out how we can show it in 3D with the red and the blue glasses.
Yeah, any problems, I'll get together with the tech and we'll test it. We'll, test it. Not televise, we'll just test it,
Yeah, sure, man, sure.
Okay, I thank you very much for today's proceedings. Very good. And we'll
Thank you,
see
thank you
next
very much.
time.
Yeah, thank you, man. Thank you so much.
Thank you, everybody.
Thank you, guys. Thank you, guys. See you guys.
All right.
Bye-bye.
Yeah, thanks, Harshad.